action. Hey, this is Brandon with Chiro. We have the ending to the shoulder seminar with adhesive capsulitis. Probably one of my favorite yet worst diagnoses that can walk in my office. And the reason it's my favorite diagnosis because when we start to treat these patients, you really can peel back all the layers of the onion that led to this diagnosis. Meaning you can go through years of dysfunction, years of postures and workstation ergonomics and sports that have ultimately created this problem. So you can learn a lot about a patient when it comes to the shoulder. And I think that this becomes a little more fun once they start to thaw out on all the interventions you can make and help these people prevent it from happening again. But hopefully by the end of this conversation, we can really look at all those individual pieces and really help these people in the long run, because a lot of people with adhesive capsulitis will get it again. There's a couple components to that. One are the lifestyle things that you can do to create this problem, and also are the systemic type issues that we can hopefully prevent to limit the reoccurrence of frozen shoulder. So diving into frozen shoulder, most people look at it as adhesive capsulitis as far as the professionals. However, or adhesive capsulitis or frozen shoulder is what the patients will often describe it as. And this is an ongoing, it's a painful limitation of active and even passive ranges of motion. So we're going to see this very frequently with a rotator cuff problem. Someone doesn't want to move their arm, and impingement syndrome and slap lesions and rotator cuff syndromes, they just don't want to do it. But passively, I can still do it. I can still passively take that arm into full flexion and abduction. With adhesive capsulitis, they can't. It's just not even available to them, that range of motion. So not only is the glenohumeral joint not moving, what we're also going to see is if it's been there long enough, we also see limitation in range of motion to the periscapular areas, into the scapula, into the rotator cuff muscles. They've really become tight, and that range of motion is often lost. Whereas with impingement syndrome and labral lesions and rotator cuff syndromes, we see a lot of limitations in internal rotation. With adhesive capsulitis, we're also going to see limitations in internal rotation, but we're going to see the hallmark thing being a loss of external rotation. Now that is a site of confusion, and we will address that in the next couple of slides, is that loss of external rotation is twofold. One, it can be due to the capsule limiting external rotation, which we're going to see with adhesive capsulitis or frozen shoulder, but also it's a possible limitation in external rotation due to that subscapularis. So someone with a rotator cuff problem that's been there a long period of time, they have a really tight internal rotator, being the subscapularis, because it's doing a job it shouldn't be doing, and you lose external rotation. So I'll show you a quick way to assess that, because some people might get lulled into thinking they have adhesive capsulitis, and they're stuck with a frozen shoulder, a pseudo frozen shoulder, but in actuality, it's just a problem with their subscapularis. I see this a lot on the internet where somebody will fix frozen shoulder in 3 minutes. That's great that you helped with their limitation of range of motion, but that wasn't frozen shoulder. You had the wrong diagnosis. If you have a true frozen shoulder, you have actual fibrosis and neurogenesis, blood vessel ingrowth, nerve ingrowth. You have swelling of the capsule, synovitis. That doesn't go away within minutes. So a true adhesive capsulitis will take a while to present and will take a while to go away. And by a while, I mean weeks to months, sometimes years. And there's other things at play, not just a magical manipulation or myofascial release. If you do something and you see resolution of range of motion, great. The patient's excited. I'm excited for the patient, but it wasn't adhesive capsulitis to begin with. So what is it? What is primary adhesive capsulitis? And this is when you have a gradual onset of pain and stiffness that just can't be explained. It's not explained by their history or clinical findings. It just started, but it's a mystery on why it started. Most of the time, this is going to be in our older individuals, and I'll explain the specific subset of patients that will get primary adhesive capsulitis. This is a little bit more common that we're going to see in our offices for a couple reasons. And this is when you have an unrelated, a shoulder immobilization due to a surgery, due to a trauma, due to a fracture. For some reason, you immobilize the shoulder. When you do that, those patients are 5 to 9 times more likely to experience adhesive capsulitis. Your bodies want you to move. You have to move. It's healthy for your bodies to move and bear load. When you have restricted range of motion due to any one of these causes, it causes an issue. So our symptoms are progressive pain, most focal to the insertion at the deltoid, and very, very sharp when you get to the range of motion, end range of motion. That end range used to be way out here. Now they can really just pick their arm up just a little bit, and it's a really sharp and uncomfortable feeling. A lot of times people will say, hey, back off, let this thing unthaw by itself, let it take its course of action. And I don't know if that's the worst option, but personally, theoretically, principle-based reasoning would say that yes, that's true, but we need to start the process. We need to influence motion because the body is designed to move. And I'm not telling you to take the person into sharp pain and yank at their arm. However, even if they have a fully frozen shoulder and it's secondary adhesive capsulitis and we know what it is, I'm still going to be working with that patient to work on maybe scapular motion, work on neck motion, work on thoracic spine motion, getting the body moving. Because what we do know is that when you have a segment of your body that's not moving, other things have to move more. And that compensatory motion sometimes is just as bad or just as painful as the primary problem. So something to think about. Now, I think that, in my opinion, one of the things that gets confused with frozen shoulder is just this. So if we have a loss of internal rotation, so if I'm off to my side and I bring my arm down, this would be internal rotation. That's not great. I did a lot of overhead sports in my life. I can maybe get 45 degrees. It's not good at all, but there's reasons behind that. Just like all of our patients have reasons. However, if I have a loss of internal rotation, I could have just hypertonicity in my teres minor, my infraspinatus, my subscapularis, supraspinatus. This is a very common problem with labral lesions and rotator cuff problems and impingement syndrome. However, when you have a loss of external rotation, that should be a light bulb moment in your practice because this is telling you something a little more significant is going on. One being a problem with the capsule, which would be more indicative of a frozen shoulder, and the other one be a problem with the subscapularis, indicative of impending frozen shoulder, or just a rotator cuff problem with the subscapularis. Remember, if you have weakness in one of the rotator cuff muscles, most commonly the one on top, the supraspinatus, the subscapularis has to work harder to move that glenohumeral joint down. So it becomes hypertonic. It's doing a job it isn't designed to do. So if you keep your arm, and I'm going to lower this down just a little bit. I'm going to lower it down even a little bit more here. And it's down here at 0 degrees, and my arm's at 90 degrees. If I try to move my arm out into external rotation, that's about as far as I can go, maybe about 90 degrees if you go from this side. Not great, but like I said, I do have a labral problem on the right side. So I do have a little hypertonicity, and I'm a chiropractor, so I have shoulder dysfunction by default. So that would be more if I had a limitation in range of motion. Let's say you're looking at me right here and I only go to 45 degrees. That's not great. There's a problem with my subscapularis probably. Now, if you want to get away from that and you abduct the arm 45 degrees, so I abduct it out to 45 degrees, now I'm dependent more on the capsule for range of motion. So at 45 degrees, now I try to externally rotate and I can't. That's indicative of more of a capsular issue and not a subscapularis issue. So once again, at 0 degrees, if I can't externally rotate my arm, subscapularis. If I can't externally rotate my arm when I'm out here, then that'd be more of a frozen shoulder. And that may seem like a small little nuance as it is. However, this could be the difference between solving someone's shoulder pain within 2 to 4 weeks and 1 year. So subscapularis issues are much easier to treat as compared to capsule issues. So in this precursor phase, we really need to decide what's causing the limitation in range of motion, because glenohumeral joints that are undergoing this this diffuse synovial inflammatory reaction that we're going to see with problems in our capsule, meaning at 45 degrees, unable to externally rotate their arm. That is a systemic problem. That's something that we need to take a look at why that's happening and to fix the offending causes. If it's just a subscapular issue, I'm going to get my thumb in there and I'm going to rough it up. I'm going to do some strengthening exercises for the other muscles and the external rotators. I'm going to work on mobilizing the scapula, whatever it may be, because a subscapularis issue is nothing more than a rotator cuff issue. That's a little more treatable. Phase 2 is a very painful process. I have never been through it in my life. This just going based off of what I hear in my practice. However, this is a gradual loss of range of motion over the next couple of weeks to months. And this is a proliferative synovitis. This is a problem that causes angiogenesis, nerve growth, neurogenesis, where nerves and blood vessels are growing into this area and are increasing the pain response to this area. But it's often likely due to a systemic response. What we see now is it's not the seed, it's the soil. It's the people in today's world have a diet and a lifestyle that's a little bit more pro-inflammatory. So these people are susceptible to the phase 2 freezing stage of a frozen shoulder. Once we hit phase 3, I do have what is she now? She's 10 years old, so she was right there in the middle of the Frozen stage, or Frozen movie when it first came out, and I can still sing every word to this song, as embarrassing as it is. But Frozen stage is one of those pieces that when it's lost. It's really not inflamed at that point, meaning it's not constantly hurting, it's just there. They're not able to go through range of motion. That fibrosis, that capsular thickening, the adhesions that are built up because of the layers of muscles and ligaments that adhere together. We see sometimes some inflammation, the subacromial bursa. We just see everything is not moving very well, not really moving at all. This prolonged immobilization can really be detrimental to the shoulder, though. Just like we know with every other part of the body, when you immobilize a joint, everything around it gets atrophy, degenerated much faster rate, and we can actually experience permanent motion restrictions. So this is a stage. I'm not going to take a sledgehammer to it to get it moving, but I also want to keep in my mind that I need to get it moving. Once they've gone out of this stage, the phase 2, and once we've gotten into this stage where it's not hurting as much, it's not inflamed, that's when I need to get some work done. And by work, I mean I need to start to progressively increasing the load, increasing the range of motion, so I can start to get this thing to, in essence, thaw out. This is not a quick process. I will admit that I don't see a lot of frozen shoulder cases in my office anymore. And the reason is because I work with a physical therapist office that does a great job of this. And it's not that I don't like treating it, and I still see the patients frequently for neck pain and upper back pain and scapular issues. However, I have the physical therapist manage these cases because it just takes too long. I have a practice that is based upon getting people in and out of pain as fast as possible. And this diagnosis just doesn't fit into my brand of what I do in my practice. So I'm not, someone that is best suited to treat these just because of the way I run my office. There's another component, though. There's another piece of this puzzle that I farm out. And the reason I do that is because I am not a dietary kind of guy. I think in the past lectures, you probably heard me say I'd rather change your religion than change your diet. And the reason I say that for this situation is when we really look at the incidence of adhesive capsulitis, it rises 10 to 20% if you're type 2 diabetic, 36% if you're type 2 diabetic. So we see that a lot of these patients, that are on type 1 and type 2, as you see here. However, 38% of men who have diabetes and 24% of women who have diabetes have signs and symptoms associated with adhesive capsulitis. So diabetics have more of these issues. The question is it truly a blood flow problem? And I think there's a component for that. But what we talked about with rotator cuff syndrome and really every other diagnosis is it's not the activities that people are doing. Your body is a self-healing organism, so your body is able to tolerate load and is able to get injured and then heal. There are some people who are not able to heal fast enough. So normally if we do an activity, we'll go through an inflammatory reaction, our body will heal and we'll move on. People with thyroid disease, people that have diabetes are unable to heal at the same rate. So these people are at an increased risk for developing adhesive capsulitis because of their failure to heal. We all do dumb stuff to our bodies on a regular basis. The question becomes, who can recover from those? I took a look at my 4-year-old who will be out on a scooter later on today, and he'll run around the scooter, he'll skin his knee 3 times, and in a week you can't even tell it's already healed. If I fell, I'd cry for the next 24 hours, and I'd still have a skinned knee 2 weeks later. We just heal faster when we're younger. Now, when it comes to adhesive capsulitis, we're going to see this more frequently in female. And if you've had it on one side, chances are you're going to get it on the other side. There's a couple different reasons for that, but I think the main take-home message to this is that this is not a primary localized lesion. This is a failure to heal response, failure to heal diagnosis, and that's not one side versus the other. Symptoms. Sleep disturbances are common, and this is usually more in the phase 1, phase 2 stage where you're going to have inflammation. If you have inflammation, you have chemical irritation of any part of your body. When you sleep, you don't have other external noises and sounds and pressures on your body. Your body's going to focus on those spots that are trying to heal or that are inflamed, so sleep disturbance is pretty common. The most common thing that I'll hear as far as an activity modification is your grooming and dressing. Just because you can't get your arm behind your back, you really can't do much at all with that arm, including doing your hair and those kind of things. So people will often need a little bit of help with those normal ADLs. When it comes into the evaluation, this is the piece that unfortunately I'm going to give you the most sensitive and specific test. And I can tell you right now that most people that I see in my practice are already in that frozen stage, and you can't do anything to them. But let's work this person up as if you don't know if they have adhesive capsulitis to begin with. We need to figure out, 1, is it adhesive capsulitis? Or 2, is it just something like a typical shoulder pain where you have loss of internal rotation? So one of the pathognomonic things that we see with adhesive capsulitis is external rotation. If you have a limitation of external rotation that is greater than 50% of the other side, then we have an issue. And this is normally measured with the arm in full or 90 degrees of abduction, and then the arm is going to be in the frontal plane. So we really want to make sure that we can assess this. You're going to look at the affected side versus the unaffected side, and if you have a loss of 50% on that affected side, I'm really going to lean onto adhesive capsulitis type diagnosis. And this is passive range of motion. This is not active range of motion. When you do things actively, then you can really, you're taking into account neurogenic or arthrogenic inhibition due to pain responses. When you're doing it passively, you're looking at pure joint motion, and adhesive capsulitis will affect the joint proper. Internal rotation, a loss of internal rotation is it's almost just normal when it comes to the shoulder. We see this, and I try to test this. I do this both lying down, both supine for the shoulder. And the reason I do that when I'm worried about a capsule is that when you can lay someone down, you're really taking all those postural muscles and putting them at rest. So I think that that's a little bit better. When the shoulder is in abduction, meaning it's way out here, you're really making the shoulder joint exponentially more unstable. So testing the joint with an abduction, really highlight capsular issues, which we've already seen with that past slide. You want to take them 45 degrees and then externally rotate them. But with whatever way you test them, make sure you test them on both sides, seated and laying down, to really get a good grasp of what's going on. And I think that sometimes you'll see passive ranges of motion that are lost, but it'll be in different ranges. So if you have passive, it really hurts there, but then you're up here and it's just fine. I'm going to lean more on an external component, maybe a specific muscle, a specific ligament that's injured. When the capsule has synovitis and is starting to develop fibrosis, it's everything. It doesn't matter what range of motion they're in. They can't get into those ranges. So something to think about. I think that whenever I look at this is I look at the actual diagnosis, and I always try to have an idea of what else could be at play. If you had to look at frozen shoulder, and if you don't think scapular dyskinesis is at play, then you missed the first couple of parts of this lecture. This is a continuum. We have a co-conspirator here, is that this is a whole line of dysfunction throughout the years that has led to a failure of healing response, a lot of it being musculoskeletal. So please, and this is one thing that I do with my patients, is not only do I once send them out for the mobilization of the shoulder, which takes a half an hour, 45 minutes, 3 times a week, but I will still see that patient frequently, once or twice a month, that I'll be working on parascapular motion. I'll be looking at controlling the scapula to help them get increase that arm elevation, and then of course looking at the cervical and thoracic spine. Manipulation of the cervical and thoracic spine will help with that nerve sensitization downstream, this being the shoulder. So there is still a big part that we can play as chiropractors in alleviating symptoms, even though the true frozen joint is going to take some time to go away. Keeping these people comfortable, allowing them to sleep, giving them advice and reassurance will also be a valuable service that we can offer. Now, in the very beginning of treatment, we're still going to look at Hawkins-Kennedy test. If you haven't looked at the impingement syndrome lecture, we went over this. However, normally be in front of the patient just for demonstration purposes. I'm not. You can hold the elbow and bring it into rotation and look at, do they have increase in pain? Normally be supporting their elbow at that point also. Sorry, just an old video for this this presentation. Nearest test is going to be the exact same. We're looking at a passive approach to the shoulder. She's going to fully internal rotate her arm, and I'm going to slowly bring her arm up into full flexion and see if we can reproduce some of that pinching sensation and pain in the subacromial space. When it comes to range of motion, I really will look at both sides, because what we see with frozen shoulder is that once you have a problem on one side, normally you're going to have it also on the other side. So we could take a look at that to see what the changes are, because let's face it, whereas 90 degrees of internal rotation is normal, they may not be that even on the unaffected side. So having a realistic goal to work towards will go a long way in helping getting that person back into their normal range of motion, back into their normal life. As far as radiology, we're not going to be able to see synovitis. We're not going to be able to see a lot of the soft tissue, considerations with frozen shoulder. However, doing some radiographs will help because we're going to see it's very common to have osteoarthritic changes associated with that. Also, keep in mind is that as we have that thing last longer and longer, that constant compression, lack of motion is going to accelerate the degenerative process. So something else to think about, that we really want to focus on getting this person out of pain as quickly as possible. So when we get into the imaging, while X-ray may not be the best option in there, we do want to focus on what we can visualize and what we can make an impact on. MRI really is appropriate when it comes to a frozen shoulder because of the duration and the cost and the time, the disability associated with frozen shoulder. We need to make sure there's nothing else going on. So MRI is appropriate to really rule out other causes of rotator cuff pathology. Normally our rotator cuff pathology is 6 weeks, maybe 12 weeks, and this thing should be knocked out. With an MRI, we're going to see that there are certain things going on with an MRI MRI that we need to be aware of. Myself, as not a DAC bar by any means, an actual radiologist is going to look for, problems with the axillary recess thickening, looking for that synovitis, looking for joint volume to be compressed and reduced. And we're going to see thickening of the rotator cuff muscles. We're going to see proliferative synovitis around the capsule. So a lot of things that can be popular with this kind of a diagnosis. But what we'll see with this shoulders, we'll often do an arthrogram, and we'll see with that arthrogram, we'll see diminished joint capsule capacity, meaning that they're not having much fluid in there. And what we know from most joints is that constant compression and motion will increase fluid within the joint, and they're just not getting it. The most common thing that I will see, once again, not a radiologist, but you'll see this axillary, or some people call it the subscapular recess or pouch, has diminished. And I think that's the next slide. Yeah. So a normal axillary pouch is just gone. So part of that capsule is being compressed, and due to that thickened, inferior glenohumeral ligament, we're starting to see that axillary pouch diminish in size. So things that we can look for on an MRI to hopefully lead us in this right diagnosis. Now, keep in mind, this is the thing that will sometimes get people. So the subscapularis, which is, the inability to external rotate at 0 degrees, is one of the failures of diagnosis, meaning this isn't adhesive capsulitis, it's something else, just a rotator cuff problem. The second one, which I've been fooled on, and it is often very difficult to treat, is a cervical radiculopathy when they have pain right here. We think of this pain, I don't want to move my arm, it hurts, and it's terrible. Sometimes the pain's not from that location. So in that case, it's more of a cervical radicular pain. We'll see a radiation to the deltoid tuberosity, very common. The way that I do that in my practice is I'll use some orthopedic tests to kind of highlight that dysfunction. Things like the arm abduction sign. Now, with a frozen shoulder case, they can't get their arm up to here. But I will say that passively, if you can get their arm up to here and rest it there and let them be dead weight with that, and if that pain goes away, it gets better with abduction. It usually leads me in a direction of more of a cervical type problem. Yes, you can do maximal foraminal compression test and see if that pain gets worse. Anything that's going to move the neck and exacerbate shoulder pain, I'd want to at least investigate the neck a little further. I also use the arm squeeze test, where you're going to create compression around the arm, and if I put compression with about 2 to 5 pounds of force around the arm and I exacerbate those symptoms, it's possibly due to compression of the nerves. If I squeeze down here and it reproduces pain up here, then I'm thinking more of a cervical radicular pain. If I push here and does nothing to my shoulder still hurts, then it's probably just more of a shoulder problem like adhesive capsulitis. So what do I do for adhesive capsulitis? I think that the biggest piece of this is really understanding where the person falls in the continuum, phase 1, phase 2, phase 3, phase 4. And then with that diagnosis, it kind of can lead the methods, lead what I'm going to do to the patient, because I know that I have to get things moving both actively and passively as fast as possible. And if I have a loss of range of motion, this is that 25 to 50% loss of internal rotation or external rotation, I need to get this moving better, because if I don't, they're going to keep on going down that process of the joint freezing, essentially. When we looked at the literature, and we do a lot of research, we have research papers delivered to us on a monthly basis in the hundreds. We'll go through the research when we're developing our condition references. It's a couple-month process. We have people who are diplomates in rehab and orthopedics and radiology and nutrition and neurology all give us this information. And I can tell you one thing, that there is a very, very specific way to treat frozen shoulder. It's throw the kitchen sink at it. And I say that in jest, but there is no single intervention that's going to help every single person with adhesive capsulitis. There's just too many variables at play. And like I said, I think I'm fairly decent at treating some of the variables. I am not qualified to treat all the variables, meaning manual therapy for adhesive capsulitis shows varied outcomes. And when you look at the literature, and the reason it shows varied outcomes is because the musculoskeletal component is only a piece of the puzzle. Manual therapy is great at improving range of motion, improving function, decreasing pain, but that's only one piece of the puzzle. There's also papers that just show supervised neglect will help these things thaw. It'll take a little bit longer of a time, but we don't need to entertain our patients with expensive treatments and modalities. And I think that there's a piece of that puzzle, but just like inflammatory arthropathies and diseases, is that people have cycles of different hormone profiles and nutritional profiles based on seasons that can affect the systemic response. Also working with diabetics, working with thyroid disease, there's a lot of other issues at play. So I'm only going to talk about the musculoskeletal component for the sake of simplicity and what we normally do. I think that when it comes to the phase 3 and phase 4, meaning it's not inflamed anymore, I need to get things moving. And what I do is I use an instrument assisted manipulation, and I go through there and I rough it up. Now, I would of course use lotion, but just for this demonstration, I'd go along all the muscles, the supraspinatus, the teres minor, the infraspinatus, the subscapularis. I'd use a tool, I'd use my hands, I'd use a sledgehammer. I would get things moving. Whatever is your soft tissue du jour, that's what you're going to want to do, and create an inflammatory response. You don't want to leave them bruised and aching and pain, but you need to start to get them moving. There's a lot of good research on instrument assisted manipulation to help dig in a little bit deeper and create a pro-inflammatory local response. We can also do mobilization. Now, there's a lot of people who will do mobilization type diagnoses. Let me turn this back on.
Mobilization of the glenohumeral.
There we go. So glenohumeral mobilization will only be directed at the ranges of motion that are lost. So checking side to side, in this case, mostly your flexion, your abduction, and your external rotation. And you really want to focus on just taking them to that range. And a lot of this is convincing the person they can get up into that range. So there's a psychological component that you're not going to hurt the person. And then once you get to those ranges, you are hitting a fibrotic block. So don't think you can push through it. You're not going to push through that, but tissue does respond to stress. So repetitive motions, stretching will help increase the range of motion, but it will be slow. You're not going to see dramatic ranges within a treatment visit, but if you can marry what you're doing in your office psychologically and physically to their exercises, they can be doing those exercises throughout the day, and it can really help make the soft tissue changes that are necessary to get these people out of pain. I think this is a very understudied type treatment, is working on the scapula. I do this on all of my adhesive capsulitis patients. I work them into upward rotation. I work them into retraction, protraction, and I really just, in every direction possible, get everything else moving, meaning even the cervical and thoracic spine. So if you look at my right hand, I guess that's in this case, it's supporting the shoulder. It's a safe position for the shoulder, and it feels good because they haven't moved that joint in a long time. So there's really no downside to mobilization of the scapula. Clearly, you're not going to get manipulation. There's no pops or cracks or capsule when it comes to the scapular-thoracic joint. However, this is a great way to get things moving, at least start the process. When it comes to management, this is where I think the gold comes in. You know, if I had to look at what I can do for somebody with adhesive capsulitis, I would say the number one piece is to teach them what they could be doing at home. There's a lot of things I can do for symptomatic results with manipulation and scapular mobilization, but I think if we really want to look at how fast people recover, it's going to be more of how much work do they put into it. External rotation is number one loss of range of motion. I think a stretch like this is very valuable. What you're going to do is use a wall to help keep a nice stable shoulder. So she's going to stand next to a wall here. What she's going to do is she's going to put her hand up against the wall, so she's not in any kind of external rotation, or just as far as she can go. She's going to push into the wall for 7 seconds, and then you can see here she's actually going to use her body to slowly try to get more external rotation. So it's a passive stretch. She doesn't have to move her shoulder at all. The shoulder is moving moving passively based on the position of her body. And with pushing, she's activating that subscapularis, and then relax, taking advantage of a little bit of neurogenic inhibition and getting some more range of motion. The more she can do this, in fact, a lot of my patients, this is going to be a 5 to 10 type a set per day kind of exercise. It might be a little uncomfortable. I do not want any of my patients in sharp pain. However, I would also tell the patient this might be a tad uncomfortable. Pain up into a 3 or 4 out of 10 is okay. If it gets above that, if it causes peripheralization of symptoms, of course, we want to back off a little bit. Working the shoulder into a normal range of motion. I think this is a big piece of it. The abduction, let's imagine her right arm is a shoulder that's frozen. She's using her left arm to assist her right arm. Now, she's not just passively pushing it up. She is really trying with her right arm here to go through abduction. It's the left arm that's going to nudge it just a little bit further to assist it as she goes up. And she's trying to regain that range of motion. So it's a combination of active and passive motion. The goal, of course, would be full active. She doesn't need the cane anymore. But when someone is symptomatic, they're going to need that cane to assist that motion to get that full range. You can also do abduction and flexion with the cane in this position where you're using them both to come up. Now, let's just take into consideration this is possibly still her right arm that's affected. I still want her in her mind to be using her right arm to go through that range of motion. The left arm is just helping in that process. So the same kind of deal. If she wanted to, she could hold the top of that cane, and as she comes up, she'd come up higher, just like you saw with the abduction. It just varies based on what the patient's comfortable doing. From the prior lectures, hopefully you guys know that I'm kind of indifferent on Codman pendulum for most diagnoses, except for this one. This is one, the Codman pendulum exercise does go hand in hand with the treatment and the recovery of this patient. And I'll load them up pretty good. Meaning I'm going to use a weight or a milk jug, something that they already have in their house. And we're really going to try to increase that range of motion passively. And when you do that, when you're leaned over and your arm's up here, I mean, technically the arm is up here, so you can really increase that range of motion. You're stretching the capsule from all different directions in a passive motion. Hopefully it's not painful. You can increase weight to distract that area and hopefully pull apart those joint surfaces, allow imbibition of fluids into that area. So I think there's a lot of positive things that come into the Codman pendulum exercise. Internal rotation is a little bit difficult, and the reason is they just don't have it. So yes, I think that performing internal rotation is a benefit. I think that we should be doing that. However, I've never seen a adhesive capsulized patient be able to do this. Instead, what they do is use the same cane that we did for the other exercises, and now they'd be doing that with this exercise where their right hand will be holding the cane, left arm will be pulling it back and forth behind the body. So still promoting internal rotation, but also keeping in mind that a lot of people can't get into that range of motion to begin with. I am not a big fan of the cross-body stretch when it comes to rotator cuff syndrome and impingement syndrome, just because it can cause a similar pain, because this is essentially a Hawkins-Kennedy test. But when it comes to adhesive capsulitis, I don't think it's the worst thing in the world. This is a way to actually stretch out the external rotators and go a little bit further, and you're pushing into your hand with your elbow, hold for 7 seconds, relax, and go a little bit further. We're just trying to get range of motion anywhere where we can get it with adhesive capsulitis. So the biggest thing is to focus on how to get things moving in a safe way. And the reason I say safe is because these people have inflamed, a sore, a limited range of motion joint, and they're a little bit nervous about it. It's been there for a long time. Nobody's giving them a clear answer on how long it's going to take to go away. It's up to us to be a voice of reason to say, all right, here's what's going on. This is going to take a while. We're going to start off by being nice to it and resting it and working on just on the scapula, working just on the cervical and thoracic spine. But once you hit phase 3, it's no longer inflamed. Then we can focus on getting things moving. Personally, for me, even when they're in phase 1 and phase 2, I'm going to be doing some scapular and glenohumeral range of motion as long as it doesn't cause sharp pain. And I'm also going to be employing some medical friends, some nutritional friends, other people that can help decrease the inflammatory response to hopefully limit the amount of freezing they have. But keep in mind that if they're in that inflammatory process, they're in that phase 1, phase 2 area, I probably don't want to be taking an instrument and scraping that area, because a lot of that's going to cause irritation and more inflammation, which I definitely do not want to do as far as my patients. So at the very end of this, with adhesive capsulitis, I think that we need to really hammer home that this starts with scapular dyskinesis, it goes through impingement syndrome, rotator cuff syndrome. You can sprinkle in possible SLAP lesions, biceps lesions, thoracic outlet syndrome on the outset, but the end result is usually adhesive capsulitis. We really need to make sure that we understand where this person falls within all these diagnoses, and also understand that when you're treating the shoulder, sometimes you are peeling back an onion. Sometimes they have seen multiple practitioners, and it's our job to decipher not only what's happened to them, but what's happening right now. Where does this person fit in the continuum, and how can we treat it most effectively? All right, so we just finished the vast majority of this entire talk. One cool thing that I find interesting is talking to the people who are doing this on a regular basis. Meaning there's a lot of times where I'm treating somebody and I think I'm doing a great job. However, I only do things based off of my own experience and what the literature tells me. So I like to communicate and network with people who are treating a very similar population, and what do they do for these specific conditions. One thing that we built into ChiroUp is the ability to look at expert advice. Meaning we have over 1,000 different clinics and over 1,400 providers around the world using our recipes. That's cool. It's always cool when you have a little bit of a standard of care out there and people doing the right thing. However, one of the coolest things that we implemented was an expert advice tab. So if you go to the actual clinical skills section, you go in the condition references and you're looking at plantar fasciitis, or you're looking at lumbar spine stenosis, what we do is we go through all of our clinics and all of our providers, and we can see who's doing the best job at each individual condition. So what I can do is at the end of the year, I can look at all the providers and all the conditions, and I can see who's getting the best results in the least amount of time for that specific diagnosis. Then they turn around and teach us what they do differently. For example, we have a clinician down in Florida who treats rotator cuff syndrome very fast. A guy in Northwestern Hospital treats plantar fasciitis very fast. What do they do differently that I'm not doing to possibly give my patients better outcomes and increase patient satisfaction? So one thing that I did about 6 months ago is I did an interview with Michael Bracchio. He's big in the ACA Sports Council and a diplomate, and what he has done is done a quick webinar with me for this talk on how he does different things with the shoulder, and I picked up a couple new things from this. So I want to share that interview with you. There's our expert advice for impingement syndrome, and here are the different things that he does to help his patients with impingement syndrome in both their examination and also the rehab.
Hey, this is Brandon and Dr. Bracchio joining me from California. Super excited to have you. Thanks for taking time out of your day to talk to our platform, but also talk to your platform.
Absolutely. You're welcome. Thanks for having
me.
So
I heard you have a kind of an interesting switch as far as professional location. So what are you doing now?
Yep. I was in private practice in Seattle for probably the last 6 years or so. Shortly, I'll actually be transitioning into my role at Crossover Health in California, which they're a on-site healthcare clinic. The one that I'll be going to is at Facebook, actually, in Menlo Park.
Oh, cool. So, I guess really, why are you making that change? Well, what drew you into that type of part of our profession?
Yeah, it's interesting because we, especially in private practice, we see a ton of musculoskeletal issues that come from just being at the workplace. And one of the issues that we see in private practice is people are just like, I have work, I can't get to you at, this time, or if I need to see them twice a week, they can't get in. But if you're actually on site, they're able to just come down, get the care that they need, and then go back. And so I think from an impact perspective, we're able to really influence people at their workplace, which is one of the areas that we definitely need to kind of tackle, especially if we're going to actually make an impact on these musculoskeletal issues.
Sure. And I think the cool part about this is we had a discussion right after the last blog, which was on Little League Elbow, and talking about the differences. You have a substandard diplomate like a rehab, or the best like an orthopedic diplomate. I'm kidding. No, you have so much carryover when it comes into the advanced credentialing, and that's what I want to talk about today. I want to figure out, where my mindset is, and then where your mindset is when you're going to treat shoulder conditions. And I talk about shoulder conditions just because we have to keep this, somewhat short for the type of video. But if we had to look at one or two diagnoses, where's your head at compared to where's my head as far as the actual tissue dysfunction that we're trying to treat? And then how do we take our education, our experience, and the things that we can gather from our resources to make an impact on that person's life? So let's get into that right now. But the first thing that I want to kind of clarify is the demographic, and that we see shoulder pain. I mean, it's the number 2 diagnosis, the reason someone's coming in to see a provider. And that's the first thing that I look at, meaning who's walking in the door and how are they supporting their arm? Is there certain things that you look for when you're looking at the most common diagnosis, like an impingement syndrome, that you almost think are pathognomonic? What age group? How are they supporting their arm? What's the typical mechanical sensitivities of, if we had to look at one diagnosis like an impingement syndrome, what are those things for you?
Yeah. So one of the things that is most striking is obviously age when somebody comes in, right? The older they get, the more likely they're going to have some sort of degenerative change, whether it's a partial tear, a full thickness tear, something like that. And so we have to kind of look at that and go, okay, well, this person could be presenting with a potential tear of the rotator cuff. Is it an acute tear? Is it a chronic tear? Is it clinically relevant? Because we also know that there's some people that have had tears their whole life, but have been pain-free. And so when we're looking at age, I think that's an important thing to kind of keep in mind, of just kind of being like, if they have a diagnosis, they had an MRI, well, if they're 50, 60, 70, the likelihood that they have some sort of structural change in that shoulder is pretty great. But is it actually what we need to focus on to help get them out of pain and then also improving their function? The second thing is always like activity level. So for me, I was in a sports clinic up here in Seattle, and so very young population, very active. And so looking at them and kind of saying, okay, well, how do we actually get them to function well? Is it actually a movement issue that we're looking at? Do they have some sort of structural issue that's actually causing their pain syndrome? Most of the time it's a functional thing. And so we just need to kind of either strengthen something, change their movement pattern to get them working again. But those are kind of like the 2 things immediately that I kind of look at and go, okay, younger person, what's their presentation? Can we actually make these changes quickly? And then kind of going from there.
That's a great point. Can we make it quickly? Because everybody wants to get out of pain instantly. Can you give me a tip, a cue, an exercise, a treatment? What is one thing that you can do within one treatment visit for an impingement type patient who wants to paint their wall, or who wants to keep up with their activity? What is something that you can do to make that impact quickly?
Yep. So when it comes to my assessment, while we're looking for like a structural diagnosis of some sort of tear or labral issue, something like that, one of the things that I like to kind of look at is if they're coming in with pain. Let's say that they're going to paint. What can I do in visit that I can show them that, one, that they don't have, that pain is not going to be forever, that we can change it, even if it's not completely resolved, but close to. And so one of the things that I'll actually do, let's see if I have anything to actually grab here, is that if they're painting, if I actually just have them squeeze a little bit harder, it'll actually engage that rotator cuff a little bit more. And
really?
So if we're kind of going, okay, if we're going to paint, I want you to pretend that you're going to try to crush this highlighter and then go up and down like you're painting. If that helps to relieve the pain, then I instantly think, rotator cuff strength or rotator cuff activation is what we need to do treatment wise. But then also if they have to paint that weekend, squeeze a little bit harder and then do your thing. That way they can get through their painting.
Oh, I've never heard that before. I'm going to look that up. I appreciate that. Now, getting into that mindset, do you start exercises day one, or there's data on both sides, calm things down before build things back up. And then I have the mindset of I'm going to rough things up and get things moving and straighten as soon as possible. And I'm not saying one's better than the other. What's your mindset?
I mean, like, as always, it depends on the individual. If someone is in a lot of pain, they are scared of moving, sure, we might lean a little bit more on the passive therapies and not really just go into exercise and strengthening. But I think for most people, if we kind of just let them know, well, we're going to do some things to work on the pain modulation aspect, but we're also going to start strengthening or changing your movement patterns now, most people are going to be on board with that. And so I always try to find something that the person is able to do day one, whether it's just they grab a lacrosse ball and we're going to just work on some self-myofascial release. If I just have them doing some active movements, whatever it is. But, most of the time I'll have them grab a band at least and do something that's within their tolerance. And, personally, I'm okay with going into pain typically. Some of the research, there was a systematic review that looked at pain with chronic issues and said that the outcomes are actually a little bit better in those that went into a little bit of pain versus a no pain approach. And so, obviously we take it into account what the actual person in front of us feels about that. But if they're okay with it and they're on board, I'm more than happy to kind of just start with that rehab approach day one if I can.
Yeah, absolutely. And I'm not positive on that paper, but one thing that I've always focused on was another paper saying that in the strengthening model, that if you're doing eccentric exercises to strengthen anything, you should feel a little bit of pain. You should feel a little bit of a pull there. And if you get to that 3 or 4 out of 10, that's okay. Jumping up a little bit higher is when we need to start asking questions, or obviously if there's any peripheralization of symptoms. But getting back to that point of the question, how many exercises or ADL modifications can you really make in one visit with somebody? I mean, can you make 15 recommendations, or can you make one, or is there a happy medium?
It depends. It depends on the person. Again, sure. Like some people, they come in with their notepad and you tell them 15 things to do. They wrote all 15 things down. They're going to do them. Most people, I'm aiming for maybe 1 to 3 because they're going to forget at least one of them. And so if I only give them 1, at least I think that they're going to remember that 1. If I give them 5, I know they're not going to remember all 5. And so I try to kind of make it very simple, and I try to pick the most impactful ones. So like your example of the painter, if there's only one thing that I'm going to do, I'm going to try to change this motion when they're painting. I don't really care that much about doing external rotator strengthening at that moment, just because that's not important to them. So they're not going to put it high up on their priority list.
Okay, so looking at their hierarchy of things that they have to accomplish in their day to make sure it fits within their schedule. Obviously, if they're a painter, they can't get on a machine, get on the floor, and do the best exercise. But you're looking at what are the things they can do to help make an impact on their daily routine.
Yeah,
Is that correct?
Yeah. One of the complaints that we all have is usually compliance, right? And so if we all have our perfect program, that if somebody comes in with a rotator cuff issue, let's say, we want you to do these 10 exercises and to avoid these 10 things. Yeah, of course. But most people aren't going to have 30 minutes, an hour to dedicate to whatever we're suggesting. And so if we can just kind of pick a couple of very important things to the patient, it helps kind of create that relationship, because they go, oh, you know what? When Dr. Steele recommended this exercise, it got me through painting. You know what? He knows what he's talking about. Let's get further into this to kind of really help with the shoulder. And so I think that's where I come from with like the most important thing to the patient, because then eventually they start to really take your advice seriously and go, oh, you know what? It was a little bit cranky. I stopped doing this. Maybe he can actually get it so it's not a problem, in the future as well.
Yeah, and that's probably the hardest part, is getting people out of pain. A lot of people are successful in that, keeping people out of pain seems to be the more difficult of the two phases of care, whatever people want to call it. But that's what gets me excited with treating rotator cuff patients, is that there is an inherent weakness in those muscles. And there's obviously a kinetic chain that goes into that. But when it comes to the actual breakdown, partial tear, full thickness tears, but when you start to have an actual weakness in the rotator cuff muscle, what are your go-to? Are there a certain number of exercises? Let's just take one of them. Let's take the external rotators. Are there certain exercises that you like the most?
Yes. It depends. If we're looking at specifically just like external rotators,
Yeah,
I actually like somebody laying on their side and doing external rotation on their side with something fairly heavy. Because a lot of times, the traditional exercise is just band, external rotation, which I feel like is typically pretty light. And so I like to actually have them on the ground, a little towel underneath their elbow, and doing external rotation that way, because then we can use a heavier weight and provide a little bit more resistance. If we're looking at strength, we need enough force to actually cause an adaptation. And so I'll do two different variations. I'll have elbow bent, external rotation, and then I'll actually have them just do a straight arm variation as well, just kind of working in a couple different planes.
So here's one that's not on our outline that I'm going to throw your way. Sorry, it's a little bit of a curveball. I apologize, but I've got to do it. So those are two exercises that I actually use also that we have within ChiroUp that I think are safe. They're effective and they're safe. However, one of the people who I admire most, who is Ben Kibler, orthopedic surgeon, and he's done a lot of leg work as far as the research. He doesn't know me, but I'm a big fan of his. And his exercises, and I have them in our program. However, they're very much quick exercises, going into quick internal and external rotation, having the arm in more unstable positions and fully external rotation from a standing position with weights. How do you feel about that? How do you feel about challenging the arm quickly as compared to loading it up and moving it slowly?
It's interesting because when we're looking at just exercise prescription, there's our common things that we can modify: intensity, duration, frequency. We could change all those kind of things. One of the things that we typically don't talk about is complexity, right? And for that example, if we're having somebody do something quickly, it's a lot harder for the system to actually be able to do that. And so I like that as a progression. Is it necessarily where I'd start with? Probably not. I want people to kind of be able to rehearse the movements first, and then build up into speed. And, that typically stems from my background in basically tendon issues, in that when we're doing a lot of like intro exercise progressions, we're using a heavy, slow exercise progression. And so we're going heavy and slow, and then eventually building up into quicker movements.
Okay. Good. Yeah, I'm taking notes. I get to learn from you today. It's really exciting for me. And I think that's really the case with most progressions. I think that if you took a golf club and made it 2 pounds, what do you think would happen?
I don't even know how much like a regular like golf club weighs. I'm not a golfer.
You'll get there once you put on a couple of years, but no, but if you're moving,
it's too frustrating.
that means you must be athletic. And one of the things that I've learned with golfing is that it takes everything you know about athleticism and reverses it. You have to go slower. You have to swing with, not as strong, play slower, think slower. We'll get into that on another interview. So
that's too much motor control for me.
I think it might be some psychological control at some point also. What about those people that do have an inherent weakness in the shoulder and they maybe have reoccurring dislocations? What about those patients?
Yeah, those are the tough ones, especially, when you've had multiple dislocations. You have to think that all of those passive structures, the ligament, the capsule, all of that is now lax. And so we have to go from, well, if the passive stability just isn't there, we have to build up active stability, which is going to be through the muscles, right? And so for those people, it's one thing just to have strength, right? So doing all of our typical rotator cuff strengthening exercises and just shoulder strengthening exercises. But we also need to make sure that the motor control is there as well, because we don't have that passive structures to kind of give us a little bit of a margin for error. So as soon as, somebody runs by us and pulls our shoulder to the side, we need to make sure that the muscles are activating, boom, right away. We don't have time to kind of go do, because at a certain point, you're going to have another dislocation. So I think for those people, we have to make sure, one, they have adequate strength, but then they also have that neuromuscular control as well.
Okay. So speaking about those passive structures, I mean, mostly that posterior capsule across overhead athletes tends to be a little bit stiffer. What do you use as far as treatment techniques in your office to help stretch that out and to regain normal range of motion?
So that's a tough one, because I'm not actually sure. In terms of actually being able to influence the actual capsule.
Okay.
From what I've seen, like doing like a sleeper stretch is one of the more common exercises. Can we do maybe some myofascial release, some instrument assisted stuff on the posterior shoulder to kind of help? Maybe, but I don't know if that actually is going to influence the capsule per se. You probably have more insight into that than I actually do.
That's why I'm asking.
I was hoping for a lifeline here, but I just don't know if we're actually able to influence the capsule as much as we're able to influence some of the other things. So, it might just be an adaptation, especially with our throwers. That's just, a protective mechanism. And so I don't know if we're actually able to make it a little, stretch it out. And even if we are able to, should we?
Oh, absolutely. I mean, you look at throwers with retroversion of the humerus, that makes them better at what they do is by getting more external rotation. So that's a whole different argument that, structure versus function doesn't matter. And even if it does matter, is it making them better at their sport, which is a tough one when you have little kids, because what is you're walking a fine line. The more that kid throws, the more he practices, the better off he will be, unless you do too much too fast, and then you're going over and above and creating issues. So yeah, I wish there was a concrete answer. One thing that I've learned about you is you should be a politician. We got to going back and forth, pleasing everybody. But if you had to really look at one thing that you're going to give me a concrete answer, does bad posture cause shoulder pain? Yes or no?
Oh man. Okay. I see what you did. If I was a good politician, I'd be able to pivot out of this, but I'm not. So I'm going to say that it doesn't, okay. Which actually might be a little bit controversial. I think bad posture can amplify some of the pain, but is it actually going to cause a lot of like structural pathologies or structural or even just pain syndromes that we see? I don't really know if it does. And the reason why is, like, if you look at everyone, I think everyone kind of has some degree of bad posture. Like, we could walk through, if malls were still busy, we could walk through the mall and point out people and go, bad posture, bad posture, bad posture. But how many of them either have had shoulder pain or actively have shoulder pain? Probably not as many as we would think. So I just don't think the association is quite there. With that being said, like, if someone is having pain, yeah, maybe if we get some extension in that mid back, pull those shoulders back, it might help with the pain. But I don't think we can say that bad posture caused the shoulder issue.
It's more of a complicating factor.
I think so. Yeah.
Yeah, and I like yourself, I do spend a little bit of time giving my opinion on social media, which is always interesting. And I think that whenever I give my opinion, I try to root it in fact. But let's be honest, our facts change as the new research comes out. And I think that what you brought up was an interesting point that there is a lot of discussion on, and it's looking at structure and pain versus function and pain. And there's a very weak correlation between structure and pain. However, what I believe, and that's a belief, this is an opinion only, is that your function will ultimately create your structure. Your function when you're growing up and the way you hold your head and the way you play baseball and the way you learn how to sit and stand and walk and whatever it is, will ultimately, you'll mold into that person. We all have that receptionist patient that walks in and they all kind of look the same because they've molded into their job. And then ultimately your structure will cause a change in the function. Once you've hit lumbar spine stenosis and it's bad enough, it's going to ultimately determine how far you can walk around target. However, making the leap from structure to pain is a big leap. So would you say as someone who would look at structure, a curve of a spine, a posture, and say, we need to correct this to get you out of pain, would you say it's a pretty big leap?
I think so. And I think one of the interesting things is that when I'm actively treating, is looking at things that are actually modifiable, right?
Yep.
And if we're going to attribute a structural issue to their pain, one, they're going to focus on that. If you're going to say, well, your kyphotic T-spine is the reason why you're in, or is the reason behind the pain, well, they're going to constantly think about that. And they're going to go, I have to change this or else I'm never going to get better. But is that actually what they need to focus on? Like, is it actually, to our point, are those actually related? Versus if we're saying, you know what, like, yeah, I'd like you to, have a little bit more extension in that T-spine, sure. But what I want you to actually focus on is I want you to go for a walk for 20 minutes each day. I want you to, you really like dodgeball, go join a dodgeball league. And I want you to play twice a week. Something that they can actively focus on, that they can change in their life. And that's going to help them with their issue versus something, that we might not actually be able to change, but yet we're telling them that that's what they need to change.
Excellent.
So, you know what I mean?
No, I do. And I think words matter. And I think that when we look at pain, you're looking at a summation of things that happen musculoskeletally, but also psychologically and systemically, and I think that some of us are really good at more MSK. Some of us may be better at the systemic with maybe, functional nutrition and that kind of stuff. And other people, and I don't do it in my office, can do better with the psychological aspect. But as long as we can find the right tool for the right patient at the right time, that we can make an impact on that person. Closing words, we're hitting that 25-minute mark, and I want to keep this somewhat short because I've learned a lot of things in here that I want to research and I want to start to implement in my practice. What's something that you know now about the shoulder that you didn't know when you first started practice?
So one of the things that has really changed how I actually approach shoulders is, especially going through school, we're so focused on figuring out like the specific cause, the specific tissue that's at fault. Supraspinatus, teres minor, subscapularis. It's upper traps are, dominant, and that's why you're not getting that upward rotation or whatever it may be. And what's really changed the way that I look at this is kind of saying, okay, some of those things might be true, some of them might not be true, but what can I actually do to modify their pain when that person's right in front of me? Whether it's, okay, we're making that fist and then going back through that range of motion, taking a band and kind of going, maybe we'll put it behind us and then anchor in front. So that way they're activating the external rotators a little bit more when they're going through that painful movement. And, obviously diagnosis is important, but really focusing on like, what can we modify that will actually change their symptoms? That's really what's changed how I actually approach the shoulder.
Sure. No, that's great. And those are the most important stuff, that if you can gain that trust of somebody within that first visit, that you can actually make a change in their pain, that's good, but also take a modifiable approach to their behavior to help get it to go away and stay away. I love that, that response. Any questions for me?
So I heard that
Nope.
Tim like lemon pepper barbecued chicken,
Lemon pep.
like putting some seasoning on it.
Yeah.
Is that the best recipe for chicken?
I don't know. What's interesting about Tim is that, well, there's a lot of interesting things about Tim. Is that, Tim is one of those detail kind of people. And he's someone that if you make him an old fashioned, make him a drink, he likes the specific portions of things. And meals, it's got to be at a certain time and a certain day. But that's one of the things that makes him great, is that he is that person that gets things done, likes things the way they are. And fortunately for us, it's a perfection. So while that may not be my choice for a recipe, that's his perfect recipe.
See, you'd be a good politician as well, because you didn't answer directly either.
I've got too many skeletons in my closet for that, but maybe someday.
Fair enough.
Well, thank you for joining me. Hopefully we can get this out pretty soon to our platforms, and let's do this again sometime.
Awesome. I agree. Thanks so much for having me.
All right. Thank you.
We're done. Thanks for listening to this entire lecture. This truly has been a learning process for me. I want to thank everybody at the Pennsylvania Chiropractic Association for working with me and hopefully working with you throughout this process. I'm a practicing provider in Illinois. Things have been difficult, but with every challenge comes opportunity. So what will you do the same, and what will you do differently after this entire process and this virus and this pandemic has gotten over? Personally, I believe that we should all be doing a lot of the same, meaning whatever you've done so far has gotten you to this point that you are now. Your patients like you, they love you, they want to get back in to see you. But don't forget about the processes that you've learned throughout this day, is that we need to have other ways of delivering information. I hope this is not the new normal. However, I do believe there is a future for chiropractic in places other than your treatment room, meaning there is no other wealth of knowledge when it comes to musculoskeletal care that we provide for our patients. So consider that. What else can you do for your patients? What services, what people, what processes can you implement to help in that process moving forward? I think patient education is one of the things that I somewhat falter or have issues with as I get busy in practice. Meaning if I have somebody waiting for me, I maybe don't educate them enough. I don't review their exercises enough. I don't work on their sleeping posture enough. And those are sometimes the most important pieces to the puzzle. So whatever you do, make sure you have a recipe to get people out of pain and have a system to measure those results. Thank you for taking the weekend with me. I hope I didn't put anybody to sleep, and I hope that in the years to come I can make it out to Pennsylvania and we can have a similar discussion on a different part of the body. Have a great weekend. It was a pleasure talking to you, and I hope we meet in the near future.